My name is Nate Goldstein, and I'm the chair of the Department of Medicine at Dartmouth Health. So where I see the field going in the next 25 years is, I think there are really two things that we need to be thinking about. One is the way that palliative care has grown and where each of us needs to be thinking about in terms of our own roles and paths within healthcare. And so, for example, I am now the chair of a Department of Medicine, and that was a big leap for me, and I think it's where more of us in the field need to go. Palliative care used to be trying to get a seat at the table, and now we're at the table, and I'm arguing that we should be leading the table, right? So instead of being at the table, we should really be the head of that table. And it's not a question about power, it's a question about how we can actually move our influence to a much larger scale, and how we think about working with others and having listening and understanding conversations to move no longer just palliative care and no longer just the care of folks with serious illness, but thinking about how we can move healthcare forward. Our skills in empathetic listening and understanding and communication actually go much beyond the patient bedside and actually can help us in the C-suite and with other departments and other sections within our institutions to really move things forward. And so we need to continue to work on broadening our own scope and our vision of what we think our role is in healthcare. Because before, we were kind of banging at the door to be let in. And now we're in, and we need to move from, please, please let us, to, hey, you should be listening to us because we have some great ways to reform healthcare. Certainly for those with serious illness, but well beyond. And the other place I see us really in the next 25 years is thinking about these new models of payment. And I think whether it's risk contracting or managed care, whatever you want to call it, or whatever is going to be next in the 25 years, no model is perfect. And we in palliative care are really good about figuring out and advocating what's right for our patients. So wherever that model is in 25 years, instead of us spending so much time talking about why it's wrong and why it doesn't work, really thinking about how do we advocate for our patients, particularly those who don't have the voice or disenfranchised from medicine or underrepresented. It's not just what the payment models are, it's instead trying to figure out how we use our voice to advocate for our patients and their families and whatever that payment model is. Because none of them are perfect now, and none of them are going to be perfect. And our role is to figure out how we help our patients and families work in the system to get the health care that they need.